Hi, student. Good evening. Now, today I will discuss regarding the ECMO. So, before going detail, Fatma is there.
Yes, sir. So shall we start now?
Yeah. So, Fatma, is there a part one student, EDIC one student also
Yeah, all the students have joined the
here?
session.
Or okay. So if in that case, I have to give first the ECMO overview, then I have to come to this session. So yeah, just a minute. Mhm. Mhm. Where's my- Anyway, I'm not able to go back. Yeah. So student, for part two student, the EDIC part two student, you just have to, you will get the ECMO as a your case variant, either from community acquired pneumonia to ARDS to ECMO, or road traffic accident followed by sepsis, followed by cardiomyopathy. Usually from the road traffic accident, they will not enter. Either they will enter from the pulmonary embolism, near arrest, and ECMO, or cardiogenic shock, then ECMO, or the commonly VV ECMO you will get from community acquired pneumonia, ARDS, then ECMO. But definitely you will get either VV ECMO or VA ECMO in your exam session. And for the student part one, you will get ECMO as a type A or K type question regarding the indication, regarding the management, regarding the anticoagulant, and also regarding the complication. So today my class focus on the CCS part 2 student mainly, but I requested Sana to allow part 1 student also. So this is your case, 34-year-old male, previously healthy, presented with fever, cough, progressive breathlessness for 7 days. He was diagnosed influenza A pneumonia and intubated 24 hours ago with severe hypoxemia, PO2 FiO2 ratio 58 mmHg, FiO2 is 1 and PEEP is 16. Plateau is 30 mmH2O despite optimized ARDS management. I'm not going to detail of ARDS management, focusing on the ECMO. Is the prone ventilation. You have given the neuromuscular blocking agent. You have done the lung protective strategy. Oxygenation remain poor. So, as a intensivist in the tertiary care hospital, what you do next? So, what are your immediate in managing this priority in managing this patient, and how will you confirm the diagnosis severity? So, who will volunteer? Who will do volunteer with me today? So, last day Priyanka was done. So, anyone, exam going student, anyone? Dr. Ankita?
This is going to be a very interactive session. Do participate in this.
Uh, Dr. Dr. Anika, are you ready? Dr. Anika?
Yes, sir.
Without yeah. So today you
Yes, sir, I can try.
yes, and no need to be scared. I am here to help you out. But what exactly I want to do more interactive, so more question we can take and we can go better way. So first thing is your first is, uh, is a severe ARDS case. Yes, you have
Yes.
done prone. So in ARDS, there are few questions examiner will ask about the definition, about your lungs protective ventilation strategy, how proning help in your oxygenation, the mechanism or principle. Then also you have to know the name of basic positive trial. The only name, if you can remember the year, that is okay. Otherwise, you have to utter the name like Procibatal in the prone
Okay.
ventilation, like Accurys trial in neuromuscular blocking agent, like low tidal volume in Armour trial, like FACT trial for your conservative fluid management. Is like that the big trial and positive trial. Okay. So
Okay,
here,
sir.
what is the what are your immediate priority in managing this patient?
So since the question it is given that we have tried all the tertiary measures like proning and other measures, so we will
Already
explain
done, already
patient
done.
yeah. So sir, we can
First,
explain for
আমি একটা ক্লাসে
ECMO.
আছি। হ্যাঁ, টমাটার কথা বলে নিচ্ছি। শোন, আমি হচ্ছে ক্লাসে আছি, 8:30টার পরে তোর সাথে কথা বলবো। So, regarding yes, continue, continue, please.
We can explain about the ECMO and there are like
Yes.
some
So here
indication
your
and
answer
all
will
those
be
indications.
yeah. Here your answer will be just sir, since we have done the all management to improve mortality and morbidity of severe ARDS like phoning, ventilation, neuromuscular blocking agent, and lungs protective strategy. Still, my patient is hypoxic, PO2, FiO2 58 means patient is in severe ARDS and PEEP is already high, plateau is maximal. So in that situation, I will go for ECMO. And if I see the Murare score saying, as per the Murare score, it's though the AVG is not provided here, but I assuming the ABG will be hypoxic. So, sir, since the persistent hypoxia, in spite of all measurement, we have only things that to make this mortality better or survival chance on ECMO and ECMO. That will be your answer. How will you confirm the diagnosis and severity of the ARDS? So here you have to tell the point where what are the your diagnostic criteria of the severe ARDS. And what are the evidence-based steps before considering ECMO? So second question, how will you confirm the diagnosis of severity of ECMO?
So, based on the diagnosis of ARDS, we will classify into 3 categories: mild, moderate, and severe. And in
Yeah,
that way, we will take PF ratio. Um,
very good.
and
Anything else?
we'll classify if the PF ratio is less than 100, then it will be severe. between 100 to 200, then moderate, and above 300, 200 to 300 will be mild ARDS. And in that case, it will come under 100, so severe uh,
Yeah.
condition. And so
So
the first,
one is your PF ratio. Anything else?
so apart from that, the another indication will be like hypercapnia along with pH less than 75, despite all the measures of lung protective ventilation. That will be another indication for ECMO.
And
And there are some other indications like patients should have a single lung failure and not any other organ involvement, MODS or sepsis. And
okay.
it should be
Anything?
reversible cause of lung involvement.
Okay.
So all the criterias are fulfilled. In that case, we will consider for VV ECMO since there
Yeah.
is single organ failure.
Yeah. So you are right. So immediate priority, your the first question was what are the immediate priority to managing this patient? Immediate priority ensure lung protective ventilation for severe ARDS patient, lung protective ventilation, optimization of the oxygen and the proning and the managing sepsis or keep hemodynamics map is more than 65. And the next question was the how will you confirm the diagnosis severity of the your ARDS? Uh, so you have to utter the name of
Early
diagnosis, the
definition.
Berlin criteria. Okay, Berlin
Yes, sir.
definition. So as per the Berlin definition, the timing, bilateral opacity, and not fully explained by cardiac failure, and P of ratio here less than 100 is the severe, and here the patient having 58. Okay. And
Yes.
also PEEP, if more than 5 is required, then it is a category on the ARDS. So here PEEP is 16. There. And next question, third question was your what are the evidence-based step before considering ECMO? So evidence-based considering একটা optimized conventional therapy, bone ventilation, recruitment maneuver, paralysis, muscular paralysis. These are the optimization of your conventional therapy. And you have done all these things. Now consider ECMO as per the Eulia criteria. If the PO2 FiO2 ratio is less than 80 for more than 6 hours or less than 50 for more than 3 hours, despite all measures, then you have to go for the ECMO. Here you have to utter the Eulia criteria. Okay.
Yes.
So coming to the next variant, ECMO candidacy and cannulation. So you have decided this patient ECMO. Now, what ECMO you will give to this patient? What ECMO you will give to this patient?
So
What
since there is
ECMO
single,
modality you will offer?
yes. So there can be VV ECMO and VA ECMO. But since there is single organ failure, lung, and considering that we will start with VV ECMO.
Okay. So the best answer is, sir, this is a purely
Lung pathology.
they have not given the in the description they have not given the hemodynamics, not other organ parameter also. So if they give, then you can utter these things. Or since they have not given, so you said that is a severe ARDS because other information is not given regarding the heart condition, hemodynamic condition, and the heart contractility ejection fraction. So I'm dealing with the respiratory failure. So I will give VV ECMO in this case. Okay. So here examiner might ask you, so what are the modality of the ECMO, you understand? So that time you can utter this, there are, as per the organ support, the ECMO is divided mainly in two parts. One is the VV ECMO, when we are giving the support to the lungs and support the oxygenation and ventilation. If we are the supportive organ is the heart, then we can offer VA ECMO, veno-arterial. The ECMO is divided into mainly three parts. One is veno-venous, and one is veno-arterial. When we are giving the lung support, we are using the veno-venous, where the access cannula and the return cannula. ECMO has two cannula mainly. One is access cannula, where from I'm getting the ECMO machine getting the blood, and return cannula, where the oxygenated blood is going going to the body. So that is called drainage cannula. So depending upon the access cannula and the drain cannula, ECMO is principally divided into three types. One is V ECMO, when the access cannula on the vein and the drain cannula on the artery, on the vein. So it can be a femoral or femorojugular. Okay. Then you have if the access cannula always be in the vein, so vein and the drainage cannula, return cannula in the not drainage, return cannula in the artery, then it is a VA ECMO. So VA ECMO we use to support the hemodynamics, the heart in cardiogenic shock. So then the in VA ECMO, drain cannula can be femoral artery, and femoral vein and femoral artery. Femoral vein is the drainage and femoral artery is the return, or direct in the you can usually femoral use, and yes. Then you have a hybrid type. Hybrid type. Okay. Hybrid type. What is hybrid type? When there is a heart and lung, both are compromised situation. Like your patient having the cardiomyopathy, septic cardiomyopathy, or the trace-induced cardiomyopathy in cardiogenic shock, along with the ARDS, then you have to give the support of the hemodynamics and support of the oxygenation. So your return cannula will be two. One is the vein, other in the artery. So your drain cannula will be in the vein, that is coming from the femoral vein, and your return cannula in the internal jugular along with the femoral artery. So this is called hybrid technology. When the arterioveno, or hybrid can be two types. Suppose one, you have started with the veno-venous ECMO for ARDS. Now patient develop cardiomyopathy or septic cardiomyopathy, or cardiogenic shock or acute AMI. The heart is not pumping. So you have to give the support to the heart also. Then from VV ECMO to you put one return cannula on the artery. The veno-venous and arterial. Or suppose you are giving the in a cardiogenic shock patient, you are giving the veno-arterial VA ECMO, and subsequently patient develop VAP and ARDS. So that time lung is not okay, so oxygenation also getting hampered. So you are putting another drain cannula in the right IJV above the your right atrium. So it's become a VAV ECMO. That is called hybrid. Just a minute. এই আমি 8:30 পৌঁছে যাব, ঠিক আছে? So that you understand the type.
Yes.
And then that question might be asked. Now here the next question, what are the criteria makes patient eligible to VV? We have discussed. And what are the contraindication? Now you tell me the indication of ECMO, VV ECMO. Indication of VV ECMO.
Yes, sir. Um,
Before we going to the contraindication, first you tell me the indication of VV ECMO.
It has to be reversible cause of lung injury, as for example, ARDS or infection related, and there should be
So
no
first
any
you tell me, just a minute. First you tell me the age of the patient. The age should be less than 65.
less than
Okay.
65.
It may be the reversible cause, but if the age is extreme, then you will not offer for ECMO. This is not the good candidate. So age should be less than 65, and then it should be reversible cause like ARDS pneumonia.
Yes,
Then
or some reversible cause like vasculitis, as for example, ANCA vasculitis or Goodbuster syndrome like that. Or when we are using
don't
ECMO as
utter all these things. Where from you get this indication, vasculitis?
generally it is given in the book.
Which book? I have a little doubt anyway.
Cause
So
manuals.
if you are confident enough, you can utter that on the vasculitis, but usually I have never seen. So the আরশাদ আমি তোকে পরে ফোন করছি হ্যাঁ So indication of venovenous, one is the age criteria, second is the refractory hypoxia, and the reversible disease. Refractory hypoxia and refractory hypoxia, you mentioned the PF ratio less than 80 for more than 6 hours or less than 50 for more than 3 hours is the indication for VA ECMO. And contraindication, irreversible lung injury along with intracranial hemorrhage, severe irreversible multi-organ failure, and prolonged mechanical ventilation more than 10 days, or contraindication to anticoagulant is nowadays is not considered for contraindication. Not the absolute contraindication, because I'm giving you example. We have done one ECMO on a patient, is a very senior consultant, the patient itself senior consultant anesthesiologist in government institute, and sir has a previously history of TB, and that develop pneumonia. Then there is a DHS, very bleeding is there, and we have done intubation, but we are not able to maintain. এই আমি একটু বিজি আছি, আমি পরে কথা বলছি, আমি 8:30টায় আসছি, ঠিক আছে? তো then what happened, we are not able to ventilate him because of the lung is flooded with the blood. Then the hemodynamics also very poor. So we have done VA ECMO, and we have not used any anticoagulant. We have uses we increase the RAM. So we will discuss later on when we will discuss the anticoagulant. So we have used high flow ECMO. So then because we are not able to give any anticoagulant in this situation, and we fight for him for 56 days. and now he has joined his own work. He's joined his service also. So, this is not the absolute contraindication for anticoagulation, where we are not able to provide any anticoagulant. Where that time we can use the flow, we can use high flow, and the anticoagulant needed to save the life of the oxygenator. So you have to keep in mind that your oxygenator maybe frequently you have to change. So next is the cannula placement. VV ECMO using femorojugular configuration or femoral. Always remember that drainage cannula and the return cannula. Drainage cannula is little higher size, 25 to 29 French, and return cannula is 19 to 21. So veno you can use femoral and femorojugular. Usually venovenous, commonly we use femorojugular. And if I ask what are the component for your ECMO machine, what are the component you have in the ECMO machine?
These are tubings.
Tubings.
So
You
one will be
say
draining
that
tube and one will
drainage cannula and the return cannula.
return cannula. There will be pump. So we will need pump for two purposes. One is to create a negative pressure to stop the blood from body, and one will create positive pressure that will push the blood through the oxygenator.
So the component is basically there are 4 or 5 parts of ECMO. One is the cannula. Cannula has a 2 part. One is the drainage cannula and the return cannula. Drainage cannula carry blood from patient to pump, from oxygenator, and from oxygenator to return cannula, oxygenated blood return to the patient. Okay, so one is cannula, second is pump. Pump is a centrifugal pump, and then there is a membrane oxygenator and the heater. Okay, this 4 part: cannula, pump, membrane oxygenator, heater. Now, why we use centrifugal pump here? What are the other pump for the ECMO?
Yes, sir, I just know about centrifugal.
Roller pump.
Yeah, so there is a roller pump also is there. Usually, in initial day when we use the cardiopulmonary bypass machine in the open heart surgery, we use the roller pump in that machine. And the beauty of the centrifugal pump, it works on the electromagnetic field, so it reduces the hemolysis, and you can increase the rate RAM of the machine from 1000 to up to 5000. Okay. And the membrane oxygenator, what is the characteristic of the membrane oxygenator? How it's work? So membrane oxygenator is made up of polymethyl pentane. Nowadays, it is made up of polymethyl pentane. There are other oxygenator also there. Non-porous polymethyl pentane is the commonly used. It has a pore less than 0.5 micron, where the blood passes, and from the outside of this pore, the oxygen and your blender gas flow is and both the flow in the opposite direction, maintain counter current, because it work on the diffusion mechanism. So the oxygen enter in the blood and carbon dioxide was out from the system. And the why heater is needed? Heater is needed to maintain the temperature, because the temperature, it is a extracorporeal circuit, and large volume blood coming from the body to from the body. So if there is a development of the hypothermia, it increase the coagulopathy and it increase the mortality. So that's why heater is needed to maintain the temperature. So what will be your initial flow? Initial flow should be your 80% of normal cardiac output. Okay. So normal cardiac output, how much is 4 to 5 liters? So 5 liter is the normal. So you keep 3.5 to 4 liter of cardiac output, and how you can maintain by 60 to 80 ml per kg per minute. Okay, so newer machine showing you the cardiac index, how much cardiac index, and the you can adjust this cardiac output by increasing or decreasing the RAM of on the console. And there is a sweep gas flow. What is sweep gas flow? What is the importance of sweep gas flow?
So it basically required to take the CO2 out from the.
Yes. So sweep gas flow is needed to wash out the carbon dioxide. So if your PaCO2 is increased in the system, you have to increase the sweep gas flow. And if the hypoxia is there, you want to increase the PaO2, then you have to increase the uh, PaO2 or FiO2 of the blender. Okay. FiO2 of the blender. Initially, you start with the now, management of ECMO. Now you have established the ECMO and how you will maintain the ECMO.
First in the beginning, sir, when we
So the
insert a
question is
tube.
describe your ventilator setting once ECMO is initiated. So what will be your ventilator setting?
It should be on the minimum level. So oxygen.
So again, you will say, I will keep the lung protective, I will continue with the lung protective strategy, and I will keep as low as possible in the FiO2 and the tidal volume, and I will keep at basic level or physiological PEEP. So your
Low
PEEP
tidal
should
volume,
be,
low peak with less driving pressure.
yes.
Peak should
And I will maintain driving pressure less than 15. So you utter this driving pressure things, okay?
Yes.
Then how will you monitor ECMO function and patient physiology? How will you anticoagulant and monitor the complication? This type of question you will get. So what will be the lung race strategy is low tidal volume. Your plateau should be less than 25. PEEP you will keep around 10, not 10 to 15, around 10. You will utter the around 10. And FiO2 is low, and avoid any de-recruitment. That's why you keep the PEEP little higher. Okay. And second important thing, the driving patient not given here. The driving patient, it should be less than 15. Now monitoring. क्या monitor करोगे? For ECMO circuit, whether flow is okay, the RAM of the machine is okay, and pre and post membrane pressure you have to monitor. Okay, so pre and post membrane monitor will tells you about the clotting on the monitor. Okay, clotting on the oxygenator. So that is actually delta P, and gas exchange, visual inspection of the clot, and the color of the two drainage and access cannula. So the drainage cannula should be bright red, and your drainage cannula is black, and the return cannula will be bright red. If there is a color difference is less, then that means your oxygenation is not happening. And also monitor the flow. Flow, how will you monitor? By checking two things. One, whether is a chattering is going on or there is any vibration on the cannula. Or second, in the RAM, you will see the like zigzag pattern the your console monitor. That means the flow up and down is happening. So how will you tackle these things? If the chattering is there or the flow up flow problem
And
is
decrease
happen, then you check the volume status of the patient. First thing, you check the you first decrease the RAM. Then second, you check the volume status of the patient. If volume status is okay, then you check whether there is a kinking on the line or not, and your RAM whether optimal or you are giving the too high. So delta P will give you the idea of your the access line pressure, where it should be less. It should not be more than -50. If more than -50, there is a chance of collapsing of the vessel. So there will be a flow disturbance. So you will keep your access pressure is around -50, or your drainage pressure, the return pressure is around 50 to 70. That will be positive pressure, and the access line will be negative pressure. Okay. And visual inspection of clot. Okay. Then do patient ABG, check the SVO2 lactate and hemodynamics chest X-ray for lung recovery and sweep gas adjustment on the CO2 control. Now coming to anticoagulant. What anticoagulant you will use? Normally we do the heparin, unfractionated heparin. Your target ACT will be 180 to 220, or anti factor 10 anticoagulant. Okay. And that you can use low molecular weight heparin. Few center is using, also recommended, but it is better to utter the heparin things. Okay. And daily screening of hemolysis, thrombosis, bleeding, circuit change if the delta P is more than 40 or rising hemolysis. Okay. And delta P means difference between, there are three pressure line, P1, P2, P3. The P2 and P3 is in the pre-membrane and post-membrane, and P1 is the in your access line. Okay. So that's there. And you keep the P1, P2 difference is around normally around 200. So if the P1, P2 gap is decreased, that means there is a clot formation in the circuit. Now, complication and troubleshooting on ECMO. So, patient desaturate suddenly while on ECMO. Outline your differential diagnosis and management. क्या हो रहा है?
There can be a block in the circuit.
Very good. Any other possibility?
There can be any
Recirculation.
complication like
Recirculation could be a reason for desaturation.
patient may be developing hemodynamic instability because of
then recirculation, clotting, and
membrane dysfunction.
Maybe the oxygen
membrane
power loss.
No
Maybe there
proper
is
anticoagulation.
blood pressure decrease.
So, always
Recirculate.
formulate the question always formulate the question like that. Ki patient issue, ECMO issue. Okay. The machine related issue, patient related issue, sudden desaturation. Okay. So first machine related issue. What is happening? Whether pump failure, pump is not working. So there is no adequate flow. Then your oxygenator, membrane oxygenator get clot formation. So it is not working. Okay. Your cannula has malposition, kinking is there, or tubing disconnected. So these are the things. So one is flow problem due to kinking, due to disconnection. Your third is you just think about the parts and you then no need to remember. So cannula problem, one is access cannula, there is no adequate flow or draining. It's maybe due to clot, due to kinking, or due to pump failure. Then come to the oxygenator. The oxygenation is not happening due to clot. Oxygenation life completed. Then come whether the return cannula displaced or return cannula obstructed due to clot. So these are the your machine related problem. Then come to the patient related problem. Patient desaturating means patient need more oxygen supply, which is more demand, or patient develops sepsis, or patient develop like you have initiated with the VV ECMO, now patient heart failure develop, so patient cardiogenic shock develop, so there is a flow disturbance, and then development of the pneumothorax, or then development of the hypovolemia. Okay, so that can be the patient related problem. Then next question is discuss the management of the bleeding while ECMO. So if this patient develop bleeding, so what will you do?
The bleeding is generally from the drainage cannula, most commonly. So we can change the dressing locally, and we can at the same time we can send certain blood investigation like a CT and coagulation profile.
Okay.
We
So
can replace.
the first thing is stop anticoagulation, give pressure bandage, identify whether your patient develop coagulopathy or heat. Okay, and assess the integrity, maintain ACT less than 160 in a high risk patient. Okay, if it is life threatening, then consider heparin reversal, or if the coagulopathy, correct the coagulopathy. Okay, how will you recognize and manage the recirculation? And in the desaturation, another differential diagnosis is the recirculation. So what exactly happened in the recirculation?
In that, basically, the blood that is going inside through the return cannula is coming back from the drainage cannula. So very less amount
Yeah,
of
so
oxygenated
that
blood is
drainage
going to the
cannula and the
tissues.
return cannula gap should be more than 10 centimeter.
More
If
than
it
10
is not
centimeter.
maintained, then whatever the oxygenated blood is going, and the access cannula or drain cannula will suck this blood. So there is a recirculation of the oxygenated blood. That's why the system is not getting the oxygenated blood. The body is not getting the blood. So patient is desaturating. Okay. So what is the measure? You have to maintain the gap by doing the T, or by doing the X-ray, by doing
Yes,
X-ray,
it can do.
you will maintain the gap. Okay. So that is your question. Then winning from the ventilator. So how will you win from VV ECMO?
So you can.
Can you see the previous slide?
previous one. Just a minute. So winning.
You win by progressively reducing the flow rate of the ECMO pump.
Yeah. So winning, you remember that it's like a ventilator winning, the ECMO winning when your patient is ready for win. One is the criteria, the lung compliance is improved, gas exchange is improved. So you progressively reduce your DO2 means blender FiO2, and you check whether your patient is maintaining saturation SpO2 more than 90% with the ventilator FiO2 is 0.5. Okay. And you check your driving patient, you check the compliance, dynamic compliance. And if the PO2 FiO2 ratio maintaining more than 150 with your DO2 is 30% and FiO2 is 0.5%, then your patient is ready for the winning. Then the stepwise you reduce by 5 minutes. Stepwise you reduce the DO2 and check whether your patient is maintaining, and then gradually you reduce the sweep gas flow and check the hemodynamics. If everything is okay, then you can go for the winning. The winning step is gradually reduce sweet gas flow, maintain native PaCO2 less than 50, PO2 is more than 60, then reduce your flow, and then you do clamp and you wait. If 2 hour after 2 hour clamping everything is maintained, then you do the decannulation. So the same day you will not win. So first day you will do gradually you reduce, then you do first day clamping. If after clamping patient is maintaining more than 2 hours, then you do second day clamping, and then you do decannulation. Ethical aspect, discuss the futility if no longer recovery more than 3 to 4 weeks, but we do 2 months together. If the patient having affordability, we check the year, but usually if within, I mean, as per the European guidelines, is for 6 weeks you have to reassess the futility, and according to you have to take decision with the combined decision from the family and your clinical decision, and also do multidisciplinary consensus family discussion, and you all follow the guideline of SLO and the ICCM regarding the ECMO withdrawal. Okay. So thank you. Thank you, Anika. You have done excellent job. Most of the answer you have given. But remember, in the this EDIC exam, you should concise your answer as minimum as possible, and they have a marking sheet. You have to utter just the correct answer, then you will get the good the marks. Otherwise, there is no negative marking, but they will not give the mark. Okay. So remember all these things, and for always follow the guidelines. Thank you all.
Thank you, sir.
Any question regarding ECMO?
Yeah, please. I didn't get the other points you raised concerning the ethical aspects. You know, for instance, after 3 to 4 weeks and the patient is not recovering, what are the how would you manage the the patients How would you just discuss with the family and disconnect the patient from the ECMO? I
Yes.
didn't get the rest of the points. Yeah.
No, this ethical thing is that after 4 weeks, as per the your ICCM and EULA guideline, that if the patient is not recovered after 4 weeks of ECMO, you have to do the multidisciplinary round, and you have to do the family discussion. We said that board meeting. So you have to do board meeting, and you have to identify what are the problem, why the patient is not improving, and if it is from reversible cause to it landed up the irreversible cause, then you have to discontinue. You have to think about that.
Okay. Okay. Thank you, sir.
Thank you.
Thank
Thank
you,
you for
sir. Yes,
Yeah.
sir. Thank you, sir. So we'll be scheduling the next session soon, probably next week.
Yeah, I need the feedback of the classes.
Sure, sir.
Okay.